all, maybe today we speak about the late problems of our patients. If the patient admitted to our department with a different localization of fractures, and you speaking with us all semester about the different localizations of fractures in your first semester, in your second semester we speak about the orthopedic problems, and this lecture it's a definition of the patient's history after 2 or 3 or maybe 4 months after injuries. That's why, like this, if I try, maybe something changed. Like this, you see the changing of my slides or not?
No, sorry, it's in the first.
It's non-work, yeah, okay. If you speak about generally about the bone regeneration, for my students, I told like this: the regeneration, generally, it's some special kind of maybe the union of fracture. It's a general, it's a special kind of regeneration. And for check any kinds of regeneration, we must see what? We must see the vessels, we must see the food for the bone tissue which try to regenerate. If we want to understand which kinds of regenerations we have, on the slides I show you that we have physiological and reparative regeneration. And you see the definition of these two processes which happened into the fracture. And the regeneration, when you study in our lessons, we told you that the first symptoms of union you can check just no earlier than after 3 weeks of the trauma. But the regeneration starts on the second after fracture. We don't check any X-ray symptoms of them, but the cells process starts to happen after 1 second of injury. And if you speak about the physiological regeneration, these things happen after fracture and without any purulent and septic problems. Reparative regenerations happen on a osteomyelitis, phone, and some others. But 2 of these regenerations must finish what? Must finish the total union of the fractures. And if we check, if we see the phases of reparative regenerations, first of them it's a restoration of bone tissue. It's dependent by the proliferation of cells in the cambial layer of periosteum and the osteum and periosteum. That's why where the reparative regeneration happened in all parts of the bones, interbony canal, periosteum, and others. And you know that all of the fractures are caused by the hematoma. In the previous lecture about the polytrauma, I told you the slide when we have a process of bone losing of blood, depending by the localization of the fracture. And you understand that, for example, femur fracture caused by 1 liter of hematoma, pelvis near than 1 liter too, more smaller bones near than 1/2 of liter. And this hematoma play a great role in bone regeneration and reparative regeneration too. That's why if you describe us the clinical picture of all fractures, you told us about the edema, about the stiffness, about the edema. The edema, it's maybe some, we can name it like a special mechanism which help all periosteum and the osteum and the other kinds of bone regeneration. That's why we don't aspirate them too. There are 4 phases in a reparative regeneration. The first phase, it's a catabolism in the tissue structures and proliferation of cellular elements. You know that we have some special cells into the bones. We have osteoblasts and osteoclasts. Osteoblasts try to grow the new bone tissue, and osteoclasts eat, maybe let's decide like this, they eat no needed bone tissue. And this balance from the catabolism and anabolism of two of these two kinds of cells guaranteed that the first phase happened. The second phase is the formation and differentiation in the tissue structures. The first and primary cells, which starts to present into the fracture, into the line of the fracture, change, or maybe starts to check the new tissue characteristics, which guaranteed and differentiation to the special kinds of the of the bone cells. The third phase is a formation and angiogenic bone structures. That's why when the first osteoblast starts to grow the new bone tissue, they need the vessels too. And you check that the bone formation happening on the second phase. And just in the third phase, we see the angiogenic bone structures, remodeling of the bone tissue. And this is so sick period. When we have problems here with neuroangiogenesis, that's why we can see the late kinds of bone malunion. And the fourth phase, it's a complete restoration and anatomical and physiological structure of the bone. If we try to make the X-rays and all of these phases, that's why the first phase happened in the first 1 week and 1/2. The second phase happened in another 2 weeks. That's why we have a totally period of these phases. It's 3 weeks. After 3 weeks on the X-ray, you can check the first symptoms of union. The third phase, it's happening how much time? From the 3 weeks to the 10 or 8 weeks. Why? Because I told you that finally union of all fractures happened after 3 months of injury. It depends by the size of the bones. We understand that phalanx bones and the femur bone, the final union of them happened in a different time and period. But here in this situation, we speak about the 3 months, and we check here the full union. And the fourth phase, when you know what you must see on this phase in a control X-ray, you must check the totally bone restoration, and you don't check any line of the fracture. That's why the fourth phase, it's a totally union of the fractures. And let's try to describe all of them more deeper. I told you about you can see the definition of the first phase. I told you 3 to 4 days, but usually it's happened near than 1 week after fracture. And we see the proliferation of cellular elements. We see the differentiation of osteoblasts to the osteoblast forms of them, and starts to see the remodeling of the bone tissue. The second phase, it's a formation on differentiation of the tissue structures. Not so interesting topic here in the trauma when we speak about the cells. Usually you want to see here that too much of different pictures of the fractures, and I told you about the histologist definitions now. But all of us, we composed by the cells. That's why we must understand all of these processes. And you see that first kind of tissue which present into the line of the fracture, it's a chondroid tissue. Second, after that, when we have a differentiation of the cells, they start to produce. After that, this chondroid tissue starts to calcificate, and after that, we see somebody show me her arm. So, and after that, we can see that the bone tissue differentiate in the more spatially characteristics of them. We start to check the compact bone layer, and we start to check the the spongios of them. The first phase, it's a formation of angiogenesis. It's a remodeling of bone tissue. Blood, it's the best food for any kinds of the cells. First of all, they need what? They need the oxygen. That's why these new vessels which starts to grow here give this new and so fresh dried tissue gives more number of protein and mineralized that. We start to see here on this stage more actuality, the form of trabeculae, and we start to check here the more maybe deep and more strong compact layer of any of tube bones. The fourth phase, it's a complete restoration of an anatomical and physiological structure. Here, I told you, check that we speak about anatomical structure and physiological structure too. Don't forget that the bones is not the same like stones. It's organs too. That's why we must, if we see the total union of the fracture, no, does it mean that the function of this bone is normal? Why? Because we must check the remodeling of intra-bone vessels. We must check that the intra-bone pressure is normal. We must check that the mechanical structures or mechanical characteristics of these bones stay normally too. That's why all of this function, all of these criteria, it's a physiological structure. And it not doesn't mean the well picture on X-ray. And these things, if we try to check the timing, it's this stage and this phase happening after, usually, let's name like this, 8 to 12 weeks after injury, depending by the size of the bone. Are you hearing me well?
Yes, doctor.
Okay, thank you. How much of us be present here? I want to check this. One second. Why the Zoom don't show me this? I think that you agree with me that new generation of Zoom work not so well like previously, yeah? Okay. Types of bone regeneration. I told you that all structures of the bone play a great role in a bone regeneration finder. That's why if we try to understand what is it, it's a periosteum, dependent or external, dependent by the periosteum of any bones. And this tissue which carried all our tube bones play a main and a first role in the bone regeneration. Why? Because just periosteum vascularizate more higher than other parts of the bones. That's why this layer of bone can regenerate faster and firstly. And if you speak about the first and second phase of bone regeneration, all of this determine of all cells happening there into the periosteal layer. Endosteal, it's a trabecular structure of any tube bones. It's an internal kinds of bone regeneration, intermediately and paraosal. Intermediately and paraosal, it's our post-fracture hematoma, when the blood which present into the hematoma play a great role there. Why? Because the growth factors which present in the plasma of our blood help the pre-osteocytes differentiate himself to the final form of the cells. And types of union, primary fusion and secondary fusion. Not afraid, I prepare for you not so big lecture today, because I understand all of you so busy, you have so long vacations, you are so tired. That's why you must present here with me not so long time. I'm right? Somebody agree with me? Are you alive, students?
Not lying, sir.
Not alive? How? I speak with the deadly persons? Or you?
No, sir.
Or you spend your holidays so hard, that's why you have not any life power into your bodies.
No, sir.
Ah. Okay, primary fusion. When the bone, if we speak about the primary fusion, it's the well results of our treatment. What does it mean? I told for all of my group that for see the well results, we must guarantee the 4 conditions. First of all, we must reduce the dislocation of the bony fragments. Secondly, we must guarantee that we have not any interposition of any tissues into the line of the fracture. Third, we must fix this bone fragments so strong. And fourth, not so dependent from us, it's a localization of the fracture. Some of the patient's body's areas so poorly vascularized. For example, it's a proximal part of humerus bone, it's a proximal part of femur, and that's why there in this localization of the fractures, all our ways for bone regeneration, periosteal and diasteal and others, don't work so full. Why? Because we have not any vessels there. That's why we can check the first and second phase of bone regeneration. We can check the proliferation of all of these cells, and that's why we don't check the final union of the fracture. And the primary fusion happened here if we work well, if we treat our patient in a well timing, for example, like this. And the secondary fusion, it's if something happened into the line of the fracture. For example, I don't know, we have open fractures which contaminate by any kinds of bacteria. If we have I don't know, some kind of special kinds of infection. If we have so long compression of the bony fragments or any areas. In this situation, we see the union or fusion of the fractures, but these things happen in a non-normal timing. And secondary, the conditions or maybe and characteristics of the new bone tissue which starts to present in the line of the fracture not so normally. That's why we try to treat our patient for check the primary fusion. Delay consolidation of the fracture. False union and factors of delaying consolidation or delaying union. Firstly, we have a different terms which describe as the delay union or delay consolidation. It's a male union, it's a non-union, and pseudarthritis. I describe just pseudarthritis for you. Why? Because male union and non-union, what is it? For example, on a control X-ray, after 3 months of the trauma, if you treat your patient well, you guarantee this 4th condition, you reduce the dislocation, you have not any tissues, you fixate, I don't know, by some operative methods, you use the on-costal kinds of fixation, it's for example, plant and screws, and after 3 weeks, after 3 months of the trauma, you see the X-ray symptoms of, I told you about this after a few slides, you see the symptoms of male union. What is it, first of all? After 3 months, you want to see what? You must not see any line of the fracture. If on a control X-ray after 3 months you see the line of the fracture, what's happening? Sorry, you don't see the full union of the fracture, you don't see the total consolidation. That's why it's a male union. Why we named it like male union and how much time another we can name this condition like a male union. Let's decide like this. The main period of the bone consolidation, it's a 3 months. In a day when the 4th month starts and you see the line of the fracture, you must name it like malunion. How much time another? Another one physiologic period of the bone union, another 3 months. That's why another 3 months, if you see the line of the fracture or you don't see the total union, you name this fracture like a malunion. Let's go next in the future. 6 months, finish it. You made the control X-ray on the first day of 7 months, and you can see the line of the fracture too. How you must name this condition? Malunion? No. You must name it like non-union. How much time? Another one period of physiologic union, another 3 months. That's why the last stage of the late complications of fractures or late complications of union, it's a pseudoarthritis or pseudoarthrosis. And you can name this structure after 9 months of the date of fracture. That's why all of these terms describe you the same process, but we change the name of these periods just depending by the timing, and that's all. Malunion, non-union, pseudoarthritis. The most common causes of the fracture healing, you can see here. I told you about the fourth, but my fourth conditions, it's here after, I don't know, 1 or 2 days of trauma. And all of these causes can happen after 1, 2, 3, or 4 months after fracture. But if you non-guarantee my first 5 causes, I think that all of this don't play a great role into your bad result of the patient's treatment. Interposition, contaminate and damage to vessels and nerves when we lose this, and localization of the fracture. Diastasis, it's my lovely definition of the malunion causes. And you can see here early removal of the retamen. Sometimes an unstable osteosynthesis. Sometimes when we finish treatment of our patient, post-operative treatment, we told him that you must process your treatment in the ambulatory conditions. And we prescribe him the mid-period of immobilization. Why? Because this micro movement in the line of the fracture, if you fix it totally and full well with the different kinds of metal constructions, but your patient starts to stand, for example, your patient have a fracture of malleolus, you prescribe him that I operate you must spend 6 or 8 weeks in a cast. Why? Because into these 6 or 8 weeks, just 2 phases of the bone union happened, and your patient need another 6 or 8 weeks for starts to present in the 4th and last period of bone union. And your patient starts to make what? Start to stand on this extremity. Some micro movement in the fracture, in the line of the fracture, guaranteed that your patient has some fracture healing. Why? Because I told all of my groups, and maybe somebody can repeat my opinion. All patients in our planet are who? My groups. I think that I told you about this. Are idiots. Don't forget about it. In a different degree, but idiots. And you prescribe him the full definition about your next post-injury or post-fracture life, and the patient non-made your prescriptions well. And that's why we have some problems. Failed joint or pseudoarthrosis. First of all, we start to see this thing after 9 months after trauma. And if we, what we can see firstly, on a control X-ray, we see the line of the fracture. Nothing happened with this structure. we can see the different kinds of pseudoarthrosis, hypertrophic, atrophic, and normotrophic. It depends how much of bone tissue grow around the line of the fracture. If we have too much of them, we name it like hypertrophic. If you don't see anything, and we see just sclerosis of bone fragments, and we see the line of the fracture, that's why it's atrophic. If you see the fracture, the position of the costal fragments may be the same like the first post-injury fracture, you name it like normotrophic pseudoarthrosis. Factors for the processing of the pseudoarthrosis. It's not so differently by the male union, but all of these things happen more, I forgot how this term is, in the future, for example. These things happen and as process in the patient's life after 2 or 3 months of injury. You see that interposition of soft tissue and others. That's why if you want to check the well result of your treatment, you must guarantee it, or you must reduce the bad effects of these factors here in the date of admission, or maybe after a few days after presenting your patient in your department when you operate him. But sometimes not all depend from you. For example, it's fractures of the femur's neck. You know that this area so badly was so poor vascularization. We have just central artery of the femur's cap, and we have 2 arteries circumflexa femori, and that's all. That's why all neck present in a maybe physiologic ischemia. And if the fractures happen then, we have not any interposition of tissues. We have not any immobilization or maybe early standing on this extremity. But after 2 months after fracture, you don't see any symptoms of union, and you must name it like a male union. After 6 months, we don't check anything, and you must name it like a non-union. After 9 months, we can see the same picture, and you name it like a pseudoarthrosis. But in this situation, some early process happened. What is it? It's a vascular necrosis. I told you when I started my lecture, I told you about the 2 different kinds of cells. It's osteoblasts and osteoclasts. Osteoblasts try to grow the new tissue, and osteoclasts destroy or maybe eat like a cells the bone tissue. And which process play a great role? Catabolism here. That's why we see that the unvascularized parts of the bone starts to destroy. We see the necrosis of them, and if we have not any infection and something else, and the cause of this necrosis, it's a vessel dependent. That's why we name this process like a vascular necrosis. And in this situation, if we speak about the fractures of the femur's neck, usually we see a vascular necrosis. We don't see the pseudoarthrosis here in this localization of the fracture. Clinical signs of pseudoarthrosis. Why we named it like arthrosis? First of all, the X-ray, and I show you the X-ray after some slides. You can check on my slides, and I made some commentaries. Pseudoarthrosis, it's like our 4 general symptoms of fracture, but they are present after 9 months of trauma. When we describe the fresh clinical scene of fracture, you tell us that, let's speak about the close kinds of, it's a pathological mobility, it's a first, it's a crepitus, it's a shortening and deformity. But if it's a fresh case, it's so painful for our patient, the patient can't make any micro movement, and some others. We have a hematoma, we have a so high intra-tissue pressure, that's why it's so painful for our patient. This situation happened after 9 months of the injury. That's why when you describe us the pathological mobility, how you check it, it's not your patient showing, you examine the pathological mobility, for example, mid-shaft of forearm. But if after 9 months you try to, you tell your patient, please show me how you move, I don't know, for example, in a mid-shaft of forearm after 9 months of trauma, and our patient have a pathology, but our patient have a pseudoarthrosis here, the patient can do that by himself. Maybe it's the patient feels some pain, but this is not so acute pain syndrome like a fresh fracture. Dysfunction and some others, you describe us all of these things when you try to describe us the primary symptoms of fracture. That's why, which changes from these two terms? Just timing of happening. General symptoms of the fracture, it's in a second of the trauma, and symptoms of pseudoarthritis after 9 months of the trauma. Radiological things. On the X-ray, you don't see anything. What's anything? You don't see any union of the fracture. You see the line of the fracture. You see the sclerosis of the bone fragments. You see the new bone spurs. You see the obturation of the bony canal. You can find some subperiosteum cysts and some others. For the tube bones, you haven't any problems for understand, is it pseudoarthritis? Why pseudoarthrosis? Because first of all, if you know the history of the patient, how much time ago this fracture happened, you know the history of her treatment, you can make the diagnosis, it's a pseudoarthritis. If you just check the X-ray without any patient's knowledge, it's so difficult for you. And sometimes we must make another examinations. If we speak about, for example, the calcaneus bone, if we speak about the pelvis, if we speak about the fractures of the vertebrae, this is a cube bone, so maybe, for example, cube bones in a foot, and in this situation, the X-ray just show you the shadow and don't show you the structures. In this situation, what's your golden standard for another investigation? It's a CT scan. The CT scan show you the layers of the bone. You check where the male union or non-union happened, where the line of the fracture happened, which parts of these bone fragments more sclerotic, which of them not, where there are more higher number of cysts present, and some others. In this situation, you can check all of this. Routine X-ray don't show you this full information. Don't forget about it. That's why for check what does it mean the pseudoarthritis, I show you some X-ray. It's a patient who have a maybe simple or not so simple bumper fracture in the mid-shaft of tibia bone, tibia and fibula too. The doctors, it's a close fracture, the doctors made a well decision. They tried to operate him by the intermedullary needle. Why? Because this is not so traumatic kind of operation. We made some small approach proximally, insert this big needle into bony canal, and after that we see, and after that fixate, and put how much 3, 4, 5 stitch that just. And this is her X-ray after, I forgot, after 11 months of the trauma. If you ask me what we can see here on this X-ray, I try to show you some my mouse. You see my mouse?
Yes.
Okay. First of all, you give me a first question. Doctor, what is it? You're right, it's a line of the fracture. The fracture happened here. And after 11 months of the trauma, we see the line. That's why, first of all, we made the first decision. It's a pseudoarthritis. Why? The timing. It's a free physiologic period of the bone healing. Secondary, which kind of pseudoarthritis we have here? First of all, we see just X-ray. That's why we can find the volume of the pathological mobility and something else. That's why we just described the X-ray here. I think that we have too much of new bone tissue which growing around the area. That's why if we name it like a hypertrophy kind of pseudoarthritis, we totally prove. Else, you can see some cysts here. You can see the sclerosis of the bony fragments. That's why it's a classically pseudoarthritis in the mid shaft of the tibia. Else, let's decide why we see it. First of all, when I with some slides ago, when I show you the causes of these things, let's start from it. We are reduct the costal fragments. Yeah. We guaranteed that we have not any interposition of the tissues. Yeah. We fixate strong. Yeah, we use the intramedullary annealing. It's so cool. Other things when we don't know, you check that these things, that this intramedullary annealing fixated proximally and distally, and this is so strong fixation. Our patient can start to stand on this extremity after 3 days. Why just 3 days? If the patient feel not any pain after operation, the patient can stand tomorrow. But it's so painful for the patient. Why tomorrow? Because these kinds of metal construction so stable and guaranteed that our patient, if it's not a fat machine, yeah, the patient can stand on this extremity full. What's happening here? The patient afraid to stand on this extremity 4 or 5 months. The patient non-stand. And we have some law, it's a Murphy, I think so, that the bone regeneration happened under some pressured power here. That's why every standing on this injured extremity stimulate the bone regeneration. And why, first of all, the patient non-stand, and secondary, we have not any pressure on this area. Why? Because it's so strong fixation proximally and distally. In the third phase of the bone regeneration, and these things happened after 6 weeks of the injury, we must take off the proximal or distal bones, the proximal or distal screws. Why? For unfixing this area, and the patient starts to stimulate her tibia area fuller. Who not do that? We prescribe all of our patients that you must take off the proximal or distal screws after 2 months of operation for not see any problems with the bone regeneration. The patient came to us and afraid about her tibia. After 11 months, we see this situation. And the treatment of the, the treatment of the, where I show you treatment is here. The treatment of the pseudoarthritis, it's so difficult surgically treatment. Why? First of all, you must take off this metal construction.